Hi, everyone. Nice to see you. Sorry I couldn't make it all the way out there. I haven't been down to Bowling Green for actually a few years. I'm Dr. Murphy. I'm at the Sanders Brown Center on Aging. I'm the Associate Director for Education. I'm also in the Department of Biochemistry. So today what I'm hoping to do is give you a general overview of kind of where basic research stands in the AD field and what our current status is for clinical trials and where I think we might be going in the future. There's kind of a lot to digest in here, so what we'll do is I'll go through it, and then we have a pretty long period for questions and answers towards the end. It varies a lot. Some of it is a little bit convoluted, so hopefully I've got it all kind of streamlined for you so it won't be too overwhelming. So I'm going to give you a little bit of an overview of Alzheimer's disease and what we believe the disease to be. Everyone knows it's the most common neurodegenerative condition that you find in the elderly. In addition to neuronal loss, there are two major lesions in the brain, and these are what we consider to be the pathologic hallmarks of the disease. So these are the things that define the disorder. There's extracellular neuritic plaques, which are made up primarily of the peptide A beta, intracellular neurofibrillary tangles, which are made up mainly of microtubule binding protein tau. We just call these plaques and tangles. Tangles are not unique to AD. You find them in lots of different neurologic disorders. So things like, for example, frontotemporal dementia often have tangles but no plaques. But plaques are a somewhat unique defining feature of Alzheimer's disease. Even though you do get amyloid deposits as you get older, they're considered to be a defining feature of the disease. What's also important to remember about AD and other types of dementias, what you're really seeing is the clinical outcome of the disorder or the clinical phenotype of the disease is really a product of the pattern of neurodegeneration in the brain. So it's really the loss of the synapses and the loss of neurons that are leading to the clinical phenotype. And those plaques and tangles are involved in that process, but the actual pattern of degeneration is what's driving the clinical phenotype. So I'm going to say a little bit about that A beta peptide. So it's the major component of the plaques, but it's not the only one. There's actually lots of other stuff that we find in the plaques as well. A lot of these are related to the inflammation that accompanies the amyloid deposits. But A beta is the first thing that you see in these deposits, and what's what we consider to be really the driving force of the disease. Now, A beta comes from a larger protein called the amyloid precursor protein, or APP, and it goes through several assembly states. So after it's cut out of that native protein, it comes out as a single peptide, and then it forms these kind of soluble intermediates that we think are toxic. We call these oligomers. And then this goes on to form higher molecular weight fibrils. And then these go on to kind of come out of solution and form these larger insoluble plaques, which then get a lot of inflammatory reactivity around them. And this contributes a lot to the long-term neurodegenerative phenotype in the disease. Now, that pathology that's spreading in the brain actually goes through very well-defined patterns of spreading. So it starts in one very small region of the brain for the amyloid pathology. Most of the time we think that the pathology is starting in the small part of the brain, which is called the precuneus. And then it starts to spread through a predetermined pattern through the brain. So it's basically spreading from that area through other parts of the brain, through the medial temporal lobe and the entorhinal cortex. And along the same time that that's happening, we also have the spread of tangle pathology. What's really important to remember here, and we'll come back to this a little later, because it's important for how we think about how we're going to do our clinical trials in the future and how we're going to approach treating the disease, is that although we think that that A beta peptide is a key triggering factor in the disease itself, that tangle pathology is another disease process that's connected to A beta, but it spreads independently on its own. So it actually spreads between neurons. This is what we call transsynaptic spreading. And that spread between neurons actually pretty nicely illustrates how it can spread through the brain, because it's really spreading along well understood synaptic pathways. So that can spread separately from the amyloid pathology. So how do we think about the disease? Well, if we're kind of thinking about the disease from the earliest stage onward, we really start to think about the disease as something going wrong with that amyloid precursor protein. So this is the first stages of the disorder. There are things like just the aging process that affect how the amyloid precursor protein is handled in the brain, a variety of pathogenic mutations that cause Alzheimer's disease. These are actually very rare. maybe only 1% of the total number of cases, but they're still very useful in telling us how the disease comes about. There are differences in people's metabolism and diet that influence how APP is handled or how amyloid is cleared from the brain, for example. And there are a lot of genetic modifiers that affect how APP is handled in the body. Those genetic modifiers are really widespread. There's a lot of them. The most commonly talked about one is apolipoprotein E, which is one of the things we screen for in clinical trials to determine what people's ApoE genotype is, because that's one of the best known genetic risk factors for Alzheimer's disease that doesn't cause the disease directly. It just affects your risk at a very high level later on in the disease. So that changes in how APP is handled leads to the formation eventually of these toxic A-beta oligomers, which we think are really important for the disease. Now, eventually they lead to the formation of the amyloid deposits in the brain, these plaques over here on the left, but also they're thought to influence the development of tangles. And a lot of our research has been directed towards understanding how these two processes interact with each other. But the oligomers on their own have some toxicity. So just that A-beta by itself is a toxin in the brain that will actually lead to loss of neurons and synapses. So it can lead to some mild cognitive problems just on its own. So all three of these things together, the plaques, the A-beta, soluble forms of A-beta, and those tangles, they all come together to kind of drive the clinical entity of Alzheimer's disease. I promise I won't have too many slides like this. So here's how amyloid gets made. And the reason why I put this up is because it's really important to understand this process to get an appreciation for how we've thought about doing our clinical trials and what we've thought to be the most important things to try first in the clinical trials to treat AD. So that amyloid precursor protein gets cut by two different enzymes. The first one is called beta secretase, or BASE, and that actually makes a cut outside the cell to release a big piece of that amyloid precursor protein. And that's probably what's involved in the main function of that precursor, but it's not thought by most people to be really critical for the disease. There's a piece of APP that's left in the membrane that then gets cut by a second enzyme called gamma secretase. And it's that second cut that releases that A-beta peptide. Then after that A-beta peptide is released, it goes on to form these higher order structures that are insoluble, and these eventually lead to the plaques in the brain. So why do we think that A-beta is really the important thing in the disease? Well, there are a lot of mutations. Remember I said these were very rare, but the rare mutations actually tell us a lot about how the disease comes about. And the reason that is even though the mutations are rare, the disease in individuals that have the mutation is pretty much exactly the same as people who do not have any mutations. The only main difference is that it's early onset, so it happens much earlier in individuals with a mutation than it does with people that don't have a genetic mutation. So this tells us that the people that have a mutation that they've inherited are actually telling us a lot about the sporadic disease. It's just much more accelerated, so they get the disease much faster. So then we think, oh, well, if we look at how these mutations affect development of the disease, this could tell us a lot about how we might treat the disease later on. So in addition to mutations that cause the disease, there actually are differences in apolipoprotein E, which are pretty well understood nowadays, even though we haven't done much to tap into ApoE as a therapeutic target. There are also a bunch of small genetic modifiers. And by small, I mean we know that they have something to do with the disease, but the risk related to them is actually quite tiny. And I'll come back to those a little bit further along. Now, just to give you an example of why we think the mutations are really informative, if you're looking at where the mutations are in that amyloid precursor protein, they are all clustered in and around that A-beta region. This is just one example of how the mutations have told us how the disease comes about. When you're looking where the mutations are, they're all falling in and around that A-beta region, which again, even though we find the A-beta peptide in those plaques in the brain, we don't necessarily know that they're causing the disease. It's the genetic evidence that really reinforces that and makes us believe that this is the driving factor behind the disease process itself. And we've actually used these to develop our animal models. Now, the reason we have to have animal models is because no animal other than humans gets Alzheimer's disease. Some animals get some forms of AD-like pathology, but nothing like Alzheimer's disease exists outside of humans. Even our closest animal relatives, non-human primates or monkeys, they don't get anything like AD. They get a little bit of Alzheimer's-like pathology. So they may have a few amyloid deposits in the brain and maybe a few tangles, but they don't get Alzheimer's disease. And similarly, things like mice and rats don't. So we have to perform genetic manipulations to create animal models that we can use to test ideas about how to treat the disease. And how we go about that is based on a couple of different principles. The first is one that I've already told you about, and that's that familial Alzheimer's disease, or the inherited form of AD, it has a very early age of onset, but other than that, it's identical clinically and pathologically to normal sporadic AD, the more common form of Alzheimer's disease. So that tells us if we were just to take mutations that we know cause Alzheimer's disease and introduce them into, say, a mouse, they'll actually get something that's somewhat like Alzheimer's disease. And the other principle is related to Down syndrome. Individuals with Down syndrome, as they get older, develop signs and symptoms that are very much Alzheimer's disease. And the reason that comes about is because people with Down syndrome have an extra copy of the amyloid precursor protein, which is in the Down syndrome region of chromosome 21. So everybody with Down syndrome eventually gets a lot of Alzheimer's-like pathology in their brain, usually by the time they're in their 40s. So that tells us if we just have more copies of the amyloid precursor protein, that will also drive the disease. So what we've seen in animal models is actually pretty simple. If you introduce mutations into mice, they'll actually develop amyloid deposits in the brain that look just like the ones you find in a human. And in fact, they actually sometimes have a lot more amyloid deposits than a human does. So this is like a greatly accelerated model of Alzheimer's disease. And if we believe that A beta pathology is important for driving the disease, that's really why we think about targeting this as our primary therapeutic target for treating the disorder. Now, if you put more mutations in, the mice get pathology even faster. Some of the animal models that the pharmaceutical industry has developed and used to test some of the drugs, they're actually almost born with pathology. This model they have amyloid pathology when they're only a few months old, which is still quite young for a mouse. So this is a way to just accelerate the drug discovery process to make it easier to find things that you could actually use to treat the disorder in people. And then the animal models have also been really useful in telling us things about how the disease process functions in a person. So one of the things that we know from the mice, and primarily from mice, is that amyloid pathology really is driving or making that tangle pathology worse. So if you have two mouse lines, one of them that has tangles and one of them that has amyloid pathology, and they have children, and what you have is the mice that are bred from that line actually have both types of pathology, just like an AD person, and the tangle pathology is a lot worse. I promise, almost done the basic research stuff. So although we know a little bit about the inheritability of Alzheimer's disease and the main things that cause AD, we don't know quite as much about a lot of the genetic risk factors that don't cause AD directly, but influence your risk of developing it as you get older. So the only one we know a lot about is this apolipoprotein E, which we know that people that carry an ApoE4 allele, which is the less common of the three typical alleles that people have, they have a pretty high risk of Alzheimer's disease. And this is from a genome-wide association study, which is, this one I think is actually looking at 75,000 people with and without Alzheimer's disease to see where the risk falls. There are a lot of smaller risk factors that we don't understand very much. BIN1, PICOM, cluster, there's a bunch of these that we don't need to talk about too much. But even though these are actually small risk factors for the disease, they could actually be really important for giving us drug targets, things that we could actually use to tap into if we were to understand their process better or what their actual role was in the disease, to actually design new therapeutics that could work. Because our track record of therapeutics has not been good. I mean, I think you all know this, that in spite of working on this problem for several decades now, since we really first came to understand the pathways a lot, maybe 20 years ago, we haven't really made a tremendous inroads in new therapeutics. And I'll tell you why in a minute why that is. So ApoE, what we do understand a lot about this, even though we haven't actually done anything therapeutically with ApoE, is that the more ApoE4 alleles you have, the greater your risk of Alzheimer's disease. So if you have two E4 alleles, you have an 80% risk of getting Alzheimer's disease in your mid to late 80s. So this is a risk factor that drives development of later onset Alzheimer's disease. So not Alzheimer's disease in your 40s and 50s, like what you would get if you inherited a mutation in the amyloid precursor protein, but just risk of getting Alzheimer's disease when you get older. And we understand a fair bit about how apolipoprotein E affects the disease. We know that it is related to how the immune system, for example, clears the amyloid peptide out of the brain and how that A beta peptide gets removed from the brain. So if you think about just how your body handles different types of waste products, and if you're thinking about A beta as something that accumulates with time, as A beta gets made in the brain, there's a process in the brain that removes it. And if that process doesn't work as well, then what will happen is, since the same amount of A beta is getting made in the brain, it starts to build up over many years. And this is why apolipoprotein E is thought to affect your risk of developing Alzheimer's disease when you get much older, because it's slowing down how or the rate of removal of that A beta peptide from the brain. Now, those other genetic risk factors we don't know very much about. They all are much weaker than apolipoprotein E. So if you're thinking about what the overall risk of ApoE is, if you have two alleles of ApoE4, your risk of Alzheimer's disease in your 80s is about 4 times what a person without an ApoE4 allele would have. But that still doesn't guarantee that you would get Alzheimer's disease. It's just increasing your risk. All of these individual risk factors are very small. So these are only increasing risk by a few percentage points. So it's not something that we screen for or you should even worry about. But they could tell us something about how the disease is developing in the brain. And some of them might be very good drug targets. All right, so where are we going here? So we know a lot about how the disease develops in the brain and what are the key genetic factors that are going on in humans and what's happening with development of pathology in the brain. So our models have never been perfect. And if we're talking about where we should go from here, the first thing we have to think about is, what of the models that we've already made, that we've been using to develop our drugs in, where are they stronger and where are they weaker? So one of the first things that came to light several years ago, after quite some time working on different models of the disease, if you're thinking about AD as a spectrum from people that don't have any cognitive problems up to people that actually have very early stage disease, mild cognitive impairment, so very mild memory complaints, up to people that actually have pure symptomatic AD, our mice really kind of fall in this spot. So these are kind of at a pre-symptomatic stage of Alzheimer's disease. So even the best types of mouse models are going to have some amyloid pathology, some tangle pathology, some inflammation. These are all things that we see in the disease. But they don't have a lot of that neuronal and synapse loss that I said earlier on, is what we think of as the key thing that's leading to the cognitive impairment, the actual thing you see clinically. So the memory complaints, right? The mice do have memory problems, but nowhere near what you would see in a person. These are very mild problems, relatively speaking, even for a mouse. So what we've done is we've actually created a model of very early stage AD, and we've been developing drugs to treat AD based on this model. And this is not necessarily a bad thing. Models are useful as long as you understand what the model is able to tell you and what it's not able to tell you. So one of the things that you could take away from this is saying that, well, since what we have done is, in our best case scenario, our mouse model is only a very early pre-symptomatic stage of the disease, what we've really been doing are working mainly on strategies that could prevent AD in people rather than treat them. And that's maybe true, maybe not. And I'll tell you a little bit of that as we go through different clinical options of what we've been trying to develop over the past couple of decades. So to think about how we are pursuing strategies of treating AD, you have to think about a little bit about what the goal would be here. Our incident rate of AD is going up by decade of life up until probably 20% or so in the mid 80s. It's probably not as high as 40% in the 90s, but it does still go up a bit. And if you're thinking about what AD is, it's that loss of neurons and synapses as you get older at a rate that's much greatly accelerated compared to just normal aging itself. Now, eventually, everyone is going to pass away at some point. If you're thinking about what the strategy should be for treating Alzheimer's disease, since it's an age-related disorder, if you understand the progression as thinking about, I guess, as a public health problem. When someone has onset of AD symptoms, sometime usually 5 to 7 years later, the caregiver burden becomes great enough that they can no longer be taken care of at home, and they end up in institutional care. Now, one of the goals should be, we don't necessarily need to cure the disease outright. Because it's an age-related disorder, if we were to develop just a partially effective therapy, so something that can bend the curve of the degeneration or just slow it down, then if we could administer something like that at a very early stage of the disease, at the initial time of someone having their first significant cognitive problem or their first clinically reportable cognitive impairment, then if we can slow it down enough from that point on, they never need to be institutionalized to begin with, so they never have to go into nursing home care, for example. But if you can take that a little bit further, then what we can think of then is, what if we could take that same partially effective therapy and move it back into that preclinical phase of Alzheimer's disease when people don't yet have any cognitive problems at all, but we can still detect the development of the disease at a really early stage. In that case, it never actually becomes a problem. You slow the disease down enough that they never even get to that level of having cognitive problems, and it becomes less of a serious health issue for the nation as a whole. And generally, this is much better for the public health system and how we could approach the disease, as a unit. If you're thinking of a good analogy for this, this is kind of like how we would think about preventing heart disease by lowering cholesterol, right? If you are in your 40s or 50s and you have elevated cholesterol levels, we try to get the cholesterol levels down because we know that if they stay elevated for a long period of time, you'll develop cardiovascular disease and other types of vascular problems as you get older. And this is primarily a preventative approach. And although there's some benefit when you get older to still keeping your cholesterol levels down, there's a big difference between someone having elevated cholesterol or cholesterol problems in their 40s versus someone who would come into a clinician's office in their late 60s and then discover that they have elevated cholesterol. By then, a lot of damage has been done and it's much harder to treat. So if we're thinking about AD as an analogy to that, then you can see that prevention is probably a much better strategy. That's not the only strategy, but it's definitely going to be more effective. Now, it should be possible to treat AD based on what we know of how the disease progresses. So there is a very long preclinical phase that we can now detect pretty well through a variety of different means. So there are markers that we can look at in cerebrospinal fluid or CSF, some that we can look at in blood, but not many yet. More typically, when we're thinking now about early detection, we're thinking about what we can see on medical imaging through both things like MRI and PET imaging. So we can tell how both inflammation is developing in the brain, how amyloid pathology is developing in the brain, how tau pathology is developing in the brain. And over the past 10 or so years, there's been a tremendous increase in our understanding about the rate of the progression of the disease and how it relates to the onset of clinical symptoms. So if you're looking at it just as a kind of general timeline down here, you've got a couple of decades from the onset of when you first start to see amyloid pathology developing in the brain. And this precedes everything else. As you get that amyloid pathology showing up in the brain, soon afterwards, you start to have some inflammation show up that's associated with that amyloid pathology. But it takes some time before tangle pathology starts to show up. That doesn't show up for maybe 10 years after the amyloid pathology has started and the inflammation has started. But even then, it's some time before you start to get loss of neurons and synapses. So you don't start to have neurodegeneration show up until much later in the development of that pathology. So by the time people first start to get sustained damage from the presence of more inflammation, more amyloid pathology, and more tangle pathology, there's already quite a lot of that pathology around in the brain. And several years after that is when you first start getting neurodegeneration. And by the time when someone shows up at a clinic with the onset of cognitive impairment, so their first signs of problems, they've only sustained a small amount of damage, but they still have quite a lot of that pathology going on. And then after that, the pathology accelerates, and this is when you get into the symptomatic phase of Alzheimer's disease. But you can see even from, there's such this long incipient phase of development of the disorder, and now that we understand the sequence of events really well, that gives us a lot of opportunities to intervene in the disease. So not only at the early stages, but even later in the disease, now that we understand how these things fit together much better. So there have actually been quite a few clinical trials in the last 10 to 15 years. And there's a lot of these, and I'm not going to go through each of them in individual detail. They fall into different categories. They're really useful to understand our evolution of thinking and how we might treat the disease. So the ones who've gotten the most press have been immunotherapies. So there's a range of these. There's just a A-beta peptide immunogen, so just a vaccine. And there are several monoclonal antibody therapies that have been tried. None of these have been successful. They're not completely done yet. They're still going on, but none of them have actually succeeded in slowing down the disease. The most recent one to end this clinical trial was aducanumab, which were the ENGAGE and EMERGE clinical trials. This one was the one that people actually thought was the most likely to work. So it had a slightly different formulation than the other amyloid therapies. And it had the best ability to remove amyloid from the brain, and the early clinical trials showed that it helped people improve cognitively and slowed their decline. And it just didn't work when it went to a larger scale trial. And this has been kind of the bane of all of these trials with amyloid removal. So all of these trials are based on the same principle. So these are all using your immune system to clear amyloid from the brain. So even though you can take someone with Alzheimer's disease and give them one of these therapies and get some of the amyloid out of the brain, it doesn't lead to any improvement in the disease. They still continue to get worse. The other strategies that have had the most attention are ones that target those enzymes that cut that amyloid precursor protein. So these are the things that actually make that A-beta peptide from that bigger protein. So there have been two of these that targeted gamma secretase. So that's that second enzyme that cuts the A-beta peptide out. Both of those, even though they had some efficacy at clearing amyloid in the brain, had some significant side effects associated with them. So they led to things like in the semagacestat trial, they had an increased risk of skin cancer, for example. And this has to do with the enzyme itself and not with the drug. So that enzyme actually does a lot of things in the body. So it was always a risky target. We knew a lot about what gamma secretase did in the body. It's important for the immune system to function correctly, for example. So targeting that was always kind of risky. So even though these did have some ability to clear amyloid from the brain, they turned out to have some pretty bad safety profiles. So they weren't going to work out as something you could use to treat the disease. And similarly, there were a set of BACE inhibitors. So this is beta secretase. That's the other enzyme that's cutting A-beta out of the amyloid precursor protein. So these had some more puzzling outcomes. So generally speaking, they did lead to some safety concerns. So these are more complicated than the gamma secretase ones. Part of that is because we don't know as much about what beta secretase is supposed to be doing normally in the body, other than what it's doing for cutting the amyloid precursor protein. And none of those really had much benefit in terms of improving people's learning and memory abilities. So without having much clinical benefit, pretty much I think all of these are out of clinical trial now. I don't think anybody is still pursuing BACE inhibitors. After that, there's a bunch of other, these are basically different categories of compounds that are largely related to managing some of the symptoms of AD. And we do need more of those, but none of these ones in particular were effective at changing outcomes or slowing cognitive decline. There have also been several attempts to target the inflammation in the brain. So these are things that are kind of the secondary fallout of that amyloid deposition. So we know that there is lots of inflammation that's associated with the amyloid deposition in the brain. And there have been a lot of attempts to target the immune system from the anti-inflammation side to kind of mitigate that damage. So we know a lot of the fallout in the brain, especially in later stage disease, is due to chronic inflammation going on in the brain. And one of the thinkings has been that if you slow that down, that can actually help people manage the disease later. And there have been several of these, there's only a small subset of them, and none of them have actually been effective. These are ones that have been much more dedicated to targeting the disease, process, like specific inflammatory processes that are involved in Alzheimer's disease versus ones that are much more general. And none of these have actually worked particularly well. There haven't been very many targeting tau so far. So this is the thing that causes tangles in the brain. There have only been a couple of these. They haven't been successful yet, but it's still very early stages for these. There have been several that have reduced cholesterol. These have not worked either. And one of the issues here is that the reason that there were trials with simvastatin and atorvastatin was for a long time we've known that there's a relationship between cholesterol and development of Alzheimer's disease, as people who, for example, take Lipitor for a long period of time have a much lower risk of developing Alzheimer's disease compared to people that don't. So it was thought that maybe this sort of strategy could be used to treat the disease, but it now looks like it's much more of a preventative type approach rather than something you can use to reverse it once it's already going. And then there have been a couple of other less typical approaches of, for example, rosiglitazone, which is mainly related to a connection between metabolic problems in Alzheimer's disease, and that has not worked either. So I don't want to make this sound like it's so horribly negative. We've learned a lot from all of these trials. One of the things that we've learned is that we've spent an awful lot of time targeting that amyloid peptide in a lot of different ways. And these are the ones that are pretty much responsible for the bulk of the clinical failures that we've had, and things have gone as far as phase 3. So we've now had 25 or 26 failed phase 3 trials, and most of them have been targeting that amyloid peptide. So these are things that drugs that block the enzymes that make amyloid, so beta secretase and gamma secretase. Inhibitors of aggregation and immunotherapy, these both sort of do the same thing. They either prevent amyloid from forming plaques in the brain or help to clear the peptide out of the brain before it forms amyloid deposits, or things that are blocking the inflammation that's thought to be the secondary damage from the amyloid deposits. But these have all been very amyloid-centric. So the strategy has been based purely around amyloid. And if you think about what I've told you about how we believe the disease comes about, that's a pretty reasonable first stage approach, because we know that the amyloid pathology is the first thing that starts in the brain as your initial sign of Alzheimer's disease. So this is telling you that removing that amyloid peptide on its own, although it might be effective as a preventative, it's not going to be nearly as effective as something that can be used to reverse the disease once it actually starts to get going. So most of those trials are amyloidocentric, and they're also one of the issues, and I don't think this is as big an issue as has been made out a lot in the press, is that most of the trials, the vast majority of them, have been populated by people who have mild to moderate to later Alzheimer's disease. So those individuals, even ones that are early stage of disease, are going to be much harder to treat. I don't think this is that big a deal with trial design, although it's certainly a concern. I think we'd have much better outcomes if we started earlier, but when most of these trials actually started going, we didn't have the amyloid imaging technology that we have now. So we didn't have the ability to monitor the disease at its very early pre-symptomatic stage. So we were really forced to deal with trial designs where you could only enroll people that were at early stages of cognitive impairment and that you could clearly say they almost certainly have Alzheimer's disease. So this was much harder to create the trials, for example. But there are several trials that have taken advantage of some of our understanding of how the pathology develops to create these prevention trials I've been talking about. So there's this Diane-2 trial, which is focused on people that have dominantly inherited Alzheimer's disease, so individuals that have mutations that give you Alzheimer's disease for sure. This A4 trial, which is enrolling people which have confirmed preclinical Alzheimer's disease through medical imaging or biomarkers or both. And an Alzheimer Preventative Initiative, which is enrolling high-risk individuals. So this is including a trial of individuals in Colombia, which are known mutation carriers. So the advantage of all of these particular strategies is that we know, I'll just use as an example, the familial Alzheimer's disease trial. We know that people that have specific mutations, for example, will develop Alzheimer's disease by the time they're 55. So because we know that they're going to get Alzheimer's disease, unless we have an intervention, it makes it much more clinically powerful to have a treatment strategy in those individuals because we know when they're going to get the disease, and because we can track the development of the disease in their brain through improvements in imaging technology, we can give them some of these drugs that didn't work for treating later stage AD and see if it prevents the disease from happening in the first place. And you can do this with relatively small numbers of people, as you don't need 5,000 people in the trial because you know all of them are going to get the disease if they don't have something by way of an intervention. Whereas if you did a trial just looking for people who are going to get sporadic Alzheimer's disease, you need to have a lot more people in that trial. So we're only now starting to get a wider net for therapies. So we've had this long focus on amyloid, so now we're trying to cast a wider net using different types of strategies. There are now currently over 100 different compounds at different stages of clinical trial. And although some of them are still very amyloid focused, there's probably more than half of them now that are targeting things other than amyloid. So that's very hopeful, I think, for the next 5 years or so in terms of new things that we can pull out that could have some promise for treating people. We do need better symptomatic treatments for late AD, so things with a better side effect profile that last longer or work for a longer period of time. And there isn't as much development going on in this area, but I think we will see some more of that going forward in the future. So there's several other things that people are only now starting to reconsider, and these are things that have come up in the media a lot recently. There are those untapped things that we've seen, those genome-wide association studies. So these are other less well understood targets, and some of those might actually be surprisingly good drug targets for developing new therapies to treat Alzheimer's disease. And people are only now starting to look at those. So there's lots of potential in there. We just don't know where it's going to go at this stage. There are two areas of AD pathology that have been around for a while in terms of we've known about these for some time. And one of these is infection. We've known since the 90s that people with Alzheimer's disease often have signs of viral infection in the brain. This is usually herpes, but there are other viruses that people have found in the brain too. They're not as robust as the herpes virus infection that's seen in people with AD. We've known about that for a long time, but no one has ever been able to connect it to development of the disease. It's possible that something has been overlooked in there. There's another area that has been around for maybe 15 or 20 years as well, and that's there have been some data going back some time showing that amyloid peptide has some antimicrobial properties, and we don't know if that's important. One of the things that's very interesting that's come out in the last 4 or 5 years is that there seems to be a connection between periodontal disease and Alzheimer's disease. And this is something that no one had any idea about 10 years ago. So it's possible that there's some unknown connection between an infection that happens elsewhere in the body and development of Alzheimer's disease. And it's possible there could be therapies that we could go or develop going down that road as well. We also know that people with Alzheimer's disease develop sleep problems, but we've never been able to figure out whether the sleep problems that people with AD develop are a cause or a consequence of the disease. We know that people with AD have fragmented sleep patterns, but it's hard to tell from what we know so far if that happens because AD is developing in the brain or the sleep problems are partly responsible for driving the disease itself. But there's a lot of sleep medications now, and it's possible that one of those may lead to a different type of treatment that we're as yet unaware of. So the things that are in phase 3 now actually cover quite a gamut of different strategies. There are still a few in there that are targeting A beta. And the reason these are still around is because you'll notice, whereas before, the strategy that people were using were looking primarily at people with moderate or mild AD. These have now moved much further back. So although this one is still a mild to moderate AD trial, there are ones that have moved to very mild to pre-AD stages. So these are looking more at biomarkers earlier on in the disease phase. So there's the things that are targeting A beta and also anti-inflammatories. There are a couple of different ones in here too. There's an anti-epilepsy medication. That's an anticonvulsant that for a while people have believed there might be a relationship between epilepsy and AD. So this is promising. It's a very early stage. And also other strategies that are more in line with trying to slow the decline later in the disease by essentially protecting neurons from degeneration. That's what this last one is here on the bottom. So there's still a lot of opportunities for one of these things to actually come out as a new therapy in AD, and they're still at the very early stages in enrolling. So these are still several years away from getting an answer one way or the other. So let's think of something a little bit different here. Imagine a scenario in which an alien civilization that doesn't know very much about us is studying car accidents. And what they see is that a car that hasn't been in an accident has airbags that are packed away and not deployed. And at any time a car is in an accident, these airbag things have come out. So they then look around and they find these rare cases where, due to a manufacturing defect or a software error, the airbag deploys it by accident while someone is driving, and this leads to a car wreck. So the aliens think, these airbags have to cause car accidents. And they can even prove this from their spaceship in orbit. They can do an experiment where they trigger an airbag deployment while someone is driving, and they find that they crash their car. And they say, there you go. If someone's airbag hits them in the face while they're driving, they're going to run into a tree. So they start to think that airbags are causing car accidents. And they think this because they don't know what an airbag is supposed to be for. This makes perfect sense to them, right? They then decide that what they're going to do is help humans by using an airbag inhibitor to turn off everyone's airbags. That's supposed to prevent this problem from happening in the future. And they beam this down by satellite into everybody's car, and they watch what happens. They're then amazed, and they find out that it doesn't do anything to affect the number of traffic accidents at all. In fact, the number of fatalities actually goes up. And although this is very confusing for them, for us, since we know what airbags are for, this makes perfect sense to us. They just misunderstood what that thing is supposed to be doing. So if you're thinking about this as an analogy for Alzheimer's disease, there's a lot going on in the AD brain. By the time the disease is actually going towards a symptomatic stage, there's a tremendous amount of damage. So there's kind of a catastrophe going off in the brain as that degenerative process is running. And you can go about changing those things that occurred early in the process all you want, but it doesn't necessarily guarantee you that those are going to affect the outcome later. So the best way to think about A beta then might be as an early trigger of the disease process. And we might actually have gone somewhere awry thinking about it as something that is solely driving the disease. But what if it's doing something different that we don't understand? We still don't, even looking at the A beta peptide nowadays, that peptide was discovered as part of amyloid deposits in the brain in 1984. And we still don't know what that amyloid precursor protein does in the brain. We don't know what its normal function is. So it's possible that we're wrong and that interfering with this at an early stage could actually make things worse. But we don't know that for sure yet. And I think we won't know that until we've gone through some of these longer preventative trials to see if it actually prevents the disease if we block it from an early stage onwards. So there's a lot of other things that we're just now starting to tap into therapeutically. There's a lot of other age-related dementias and a lot of pathology that develops in your brain as you get older. It's really rare to find someone in their 70s and 80s that doesn't have any brain pathology of any kind. We're Americans, we live in America in the 21st century, we don't eat well, we don't exercise well. It's super rare to find someone that has a really healthy brain when they're in their 80s. Now, it doesn't always rise to the level of dementia, but there's certainly lots of pathology. So that pathology is usually mixed. So even though 60% of our cases of dementia are AD, and our next biggest category of dementing illnesses is related to cerebrovascular disease. And this is not just strokes. These are things like multi-infarct dementia, or even mild atherosclerosis, or just arterial blockages in small areas of the brain that just happen to be in an unlucky spot. These can lead to all types of different dementing illnesses as well. But there's a big area of overlap in there, and we call this now vascular cognitive impairment as it relates to AD, or VCID. And this interaction between vascular disease and Alzheimer's disease is something that people have only really started actively working on in the last 10 years. And it's possible that tapping into those areas where we have overlapping types of brain pathology may actually lead to some really clever new therapies that we haven't come anywhere near anticipating yet. So where does that leave us? Well, we know that there's nothing we can really do about aging or mutations that people might have, or even these genetic modifiers that are going to prevent AD. There's a lot we can do with diet and metabolism, and we haven't talked much about that. We know that, for instance, people that are either pre-diabetic or diabetic or even overweight from middle age onwards, or people that don't exercise much, are at a much higher risk of Alzheimer's disease as they get older. But I don't know if y'all know this, but people are really bad at controlling their diet and metabolism or exercising well. It's actually really helpful to tell people that they should be eating better and exercising more, but people don't do that well. Hopefully that will improve in the future, but who knows? I mean, that is something that will slow down development of Alzheimer's disease, or at least reduce the rate of Alzheimer's disease incidence. We do have a lot of things that can interfere with that development of amyloid pathology in the brain. So we can now actually, with early detection, we can approach this problem purely as something as a preventative exercise, where we could treat people with very, very early signs of Alzheimer's disease and remove that amyloid pathology from their brain from an early stage. So it's possible that in the future, AD may become something that's more akin to how we would approach cerebrovascular disease or cardiovascular disease, where in your 40s and 50s, you would be screened for, in addition to your cholesterol levels, you'd look for your amyloid levels in your brain. And you say, well, you're at risk of Alzheimer's disease in 20 to 30 years, so we need to get these amyloid levels down. And we would give people something that would reduce these. And we already have lots of these compounds that didn't work in phase 3 clinical trials for mild to moderate AD, but may work really well as a preventative. Now, we haven't done much with this tangle pathology yet. And that tangle pathology is really important for killing neurons. So we know that the amyloid pathology is driving the tau pathology to some extent. So once we have things that can target tau pathology, then we can think about treating the disease in a more complicated way or a more complete way, and we can think about it maybe as combination therapies. So since we understand how the disease is progressing, we could think of it as kind of a multi-stage problem. So if you screen people in their 40s and 50s for where they stand for their Alzheimer's pathology, you may be able to think, okay, here's where we would try to prevent it by lowering amyloid pathology in the brain. And then a little further along, if it hasn't slowed down or we catch people later, say in their 60s, then you might think of a preemptive treatment where you would treat that tangle pathology, the amyloid pathology, and the inflammation all at the same time. And again, this is going to be all before people actually start to show signs of cognitive impairment. And then once people show up and have actual early stage cognitive impairment, then you would be more aggressive and you would combine removal of tangle pathology and amyloid pathology and inflammation with some sort of symptomatic relief. So something that would improve people's memory function so they wouldn't decline any further. And this is actually a pretty wide window. One of the things that's remarkable about your brain is that you can actually lose quite a few neurons and synapses before you have some really profound problems. So anywhere in the early stage disease should be a good spot to intervene, provided we have enough tools at our disposal where we could tackle the problem at this stage. Later on, it's going to be harder. So once people progress past that early stage of the disease, then you're thinking about how you can heal the brain or reverse the pathology. And this is theoretically possible, but it's not going to be easy. This requires repairing lost connections in the brain, replacing lost neurons. So you could think about how you might do this using, say, engineered stem cells or growth factors. And a lot of that research, we can't anticipate where it's going to go these days. A lot of people who are working on things like spinal cord repair are working in those areas. And it's possible we may solve this problem at some point in the future. But for now, I think our focus has to be primarily on stopping the progression of AD rather than reversing it.